for opioid use disorder, a team-based approach, and this is really looking at the components of a successful practice. As Rachel mentioned, Dr. Bhatt usually is the one who does this presentation, so if you have any really clever questions, I'll probably refer you to him. But these slides were originally created by Dr. Bhatt and then also were adapted by Dr. Lindsay from UNM's ASAP clinic. So our objectives today are to describe the importance of using a team-based approach, to identify the team members recommended for an office-based buprenorphine program, to describe the roles and responsibilities of each team member, and to address how your administration can support building a team and recognize how the information provided can assist you in your clinical setting. And I'll just say before we dive in, I think this is one of those topics that might sound a little dry, but I'm always excited to present on this because I think it's one of those things where as a provider, you really recognize when you're in a setting where providing these services is really supported and sort of path is smoothed for you, and it makes things so much easier. So anything that we can do to help give people ideas about what models to use and how they can sort of integrate this with their regular practice to make things easier for both patients and providers, I think it can make a really huge difference for all involved. So the big idea here in terms of using a team approach to leverage resources, I'll talk more in a bit about where these models come from, but the idea is really about extending capacity. We know certainly here in New Mexico, and I know we have some participants today from outside of New Mexico, but most prescribers especially seem to feel overextended. There are more patients than most providers are able to handle. And we really want to make sure that we're doing everything we can to provide quality services while making sure we're also being as effective as possible with using every member of the team. So that's kind of the idea at the heart of this model is making sure everybody on the team is able to, do the job to the best of their abilities and that patients have the fewest barriers possible to access. So in terms of treatment teams, because this is important as a sort of prefatory note for this presentation, integrated treatment, meaning multiple service providers working together, is the research-proven model of treatment for people with SMIs, serious mental illnesses, and co-occurring substance use disorders. So really all of the bodies of regulatory and research that we would want to listen to in this practice do consider integrated treatment to be the gold standard treatment approach. It allows patients to receive combined treatments for mental illness, substance use, and psychosocial needs from one treatment team who meet regularly to coordinate care and to convey a consistent message about treatment and recovery. And that's really a theme here is the team cohesion and consistency. I think, we're all providers and we're used to seeing it from this perspective, but also if you or a loved one has ever received healthcare for a complex or a chronic medical issue, there's a good chance you've had the experience of needing to, call a whole bunch of people to figure out, just the one person you need to talk to or to figure out how to coordinate schedules for all the providers, et cetera. And it can be so demoralizing. So for this population, which we know is very often already alienated from the healthcare system and, may already be ambivalent about accepting treatment, we really want to make it as smooth as possible for them to be getting the care that they need. And a big part of that is making sure that their treatment team is all communicating well and is all on the same page. So on that note, there is actually a technical difference between the terms multidisciplinary and interdisciplinary. I think they're often used interchangeably, but ideally we do want treatment teams to be interdisciplinary to meet that gold standard protocol. So multidisciplinary means several disciplines that are doing their separate pieces, whereas interdisciplinary is where you have the confluence of all those different providers from different disciplines talking together. So rather than kind of being siloed off and each just doing their own piece, interdisciplinary means all very much on the same team, all meeting at the same table, bringing those perspective and ideas together so that there's really a synthesis when the team formulates a treatment plan and implements it all together. So in terms of how we define recovery, this is an important treatment team concept. People often think first of recovery as, the sort of metrics of symptom remission and stabilization, but certainly from the behavioral health side, we do conceptualize recovery as involving a much wider and sort of higher order network of factors. So that includes things like developing a new sense of meaning and purpose in one's life. SAMHSA actually defines hope as really the cornerstone of recovery. So just keeping in mind as we're putting the treatment team and the treatment plan together, thinking about what recovery means for this individual patient and the fact that it is going to be more than just the sort of quantitative aspect of, whether they're using less or they've ceased use already, but really that larger constellation of psychosocial and psychological considerations. For the treatment team, it's so important to include all of the people who are going to be working directly with the patient or who have significant influence in their life. And most of all, making sure that the patient themselves is included in the planning process all the way along. That's so critical. Dr. Bott likes to use that phrase of they're the captain of the ship, the patient. And that's not just because, it's what's expected. It's also just from a strategic perspective. If the patient doesn't have a sense of ownership of the treatment plan, it's developed by the team, but the patient needs to recognize themselves in the plan and to understand why all the pieces are in there. Then you really don't have their buy-in. So there's a substantially less likelihood that they're actually going to follow through, and that means the whole treatment team's work is for nothing. So really making sure that the patient has bought in and is on board. And then similarly on the team side, you want to make sure that an infrastructure is in place in order to promote team cohesion and allow the team to focus on clinical work. It's an experience that so many providers have across settings that a lot of their really valuable time is taken up with things that are really not part of their principal role or are, paperwork or something where it's, relatively low on the pyramid of their skills. And when we're following this idea of, how do we leverage capacity, one of the biggest points here is making sure that everybody gets to focus on the role that they are uniquely qualified to do, and that they're able to work together effectively in that way. And lastly, on the treatment team concept, it's so important to remember that everybody needs to keep returning to the treatment plan as this sort of touchstone throughout treatment. It is the fundamental underpinning for all of the clinical encounters and interventions. And following best practice, it should be updated regularly to reflect any kind of changes in treatments or changes in the patient's goals or perspective on treatment. And we need to make sure that it is there written down in the treatment plan rather than just discussed informally, because that is so important to guide treatment. So in terms of the components of a successful team, you can see here program manager, recovery coach, therapist, pharmacists, advanced practice nurse, and physician assistants and physicians. That's a sort of classic structure of a successful team, but there are quite a few variations. And again, the focus here is on leveraging capacity. So making sure that all the staff on the team are able to work to the best of their abilities in their own roles. So in terms of who's on the team, we can look at it as sort of like two layers. The first being the core team. So that's the client and then the primary treating providers who work with the client. As far as the extended team, which is this sort of constellation that orbits around the core team, that includes any service providers who work with the client less frequently at other agencies or might otherwise be involved in the client's care. So that does include concerned significant others. It's not only medical or behavioral health professionals. So an example here in terms of a common member of the extended team might be a dentist. We know this population, there are often some fairly significant dental concerns that can link to other medical concerns. And since this population also very often has a history of trauma, receiving dental services can sometimes be very difficult for them, having somebody right up front, right in their face with sharp equipment. And these are all concerns that when the core team is working with the extended team, they can make sure that the patient is going to be getting the best care possible, with all the information that could be helpful for this extended team member to know in order to provide that care. In terms of the structure of the team, we'll dive into this in more detail in a moment, but you do need to have a team leader, a manager that's responsible, again, for the treatment plan. Can't emphasize enough how important it is to keep returning to the treatment plan and keep it updated, and then also responsible for the team as a whole. So often that's the primary person who's working with the client. Then you'll have a coordinator or a recovery coach who's responsible for organizing the team meetings, facilitating communication, making sure that all the documents and the information are tracked and recorded in the treatment plan. So that goes back to that idea of everybody having the role that they're responsible for so that everyone can focus, on their responsibilities instead of everybody kind of piecemeal trying to make sure that the documentation is together and that everything is going as planned in terms of the EHM. So the idea here is the sort of balance of flexibility and structure. So you need to have those defined roles for all of the team members so that people can concentrate on what they're best qualified to do. And then also at the same time, we know that sometimes our coworkers can't show up every day. Today we have a relatively small team here for good reasons. And it's important in those cases that we can step in where it's appropriate so that care can continue uninterrupted for the patient whenever possible. For the team lead slash program manager, so that could be a physician, a registered nurse, a physician's assistant, a nurse practitioner, or an independently licensed therapist. The main idea is that you really want there to be one consistent point of contact for patients. And again, going back to that sort of the qualitative understanding that many people have of the healthcare system as being very difficult to navigate, kind of being this labyrinth of who do I get in touch with for what, and having one consistent point of contact is one of the most direct ways to reduce attrition because that way people really understand who they have a relationship with and who they can go to if they have questions or concerns. So that person is going to coordinate communication between team members as well as between the team and the patient, so there's that sort of liaison role as well. They may also have some patient care functions, and perhaps as qualified can conduct support or education groups for the program. I'll say now, and we'll talk about this more in a moment when we look closer at the models, but nurses have been the ones who have most often been studied and utilized in this capacity. And as we'll talk about in a bit, when they're properly supported and the role is carved out for them, it's really extraordinary what a high volume of patients they can provide high quality care to if again they're supported effectively. For the recovery coach slash engagement specialist, this could be an RN, a community health worker, a medical assistant, or a peer support specialist, among others. It does require training to step into this role. And again, the main idea is to expand services on the administrative side. That could be with things like prior authorizations, which we know are a big part of, where the system kind of gets snarled up, checking the PMPs and maintaining buprenorphine logs. On the clinical side, as qualified, doing UDSs, pill counts, administering rating scales of vital signs, et cetera. On the patient education side, I want to just highlight here, I have seen peer specialists absolutely shine in this role. I think they do a great job of communicating things like the basics of buprenorphine in language that makes sense to and that community members receive easily, outlining program expectations and requirements in a way that's not too daunting, explaining the harm reduction model and linking to resources for that. For patient education, it's important to be able to have other team members tap in where appropriate. So for example, if it is a peer support specialist, then they would want to maybe tap in an RN or an MD to provide a complicated medical explanation to make sure that everything's being included. And then on the psychosocial support side, also checking in with the patients, offering support. We've talked a lot on this echo about that importance of establishing rapport, especially early on, and making sure patients know we're thinking about them, wanting to make sure that things are going well, particularly at the beginning. Making necessary referrals, and then again, those check-ins, which could be phone or in person. In terms of possible referrals, there's a pretty wide range here, and it could be anyone on the team. You just, again, want to make sure that everyone knows that the referral is being made and that that's in the treatment plan so that it's neither duplicated nor forgotten. So that could be things like Alcoholics Anonymous, Narcotics Anonymous, SMART, Smart Recovery, traditional healing modalities, if that's appropriate to the person's community. Inpatient treatment programs, harm reduction sites, so things like syringe exchanges, overdose prevention, Narcan distribution, and then also HIV and hepatitis testing and treatment services. Ideally, you want to have those on site if that's available through the resources of your agency. But if not, connecting them to somewhere in the community that's accessible and that they're likely to be willing to go to can very literally be a lifesaver. So ideally on site, but if not, absolutely linked to the most accessible options. And then also direction to resources for things like emergency food resources, housing and utility, and then employment and education resources. I've worked at a few agencies where we have some specialists for this, and it makes a huge difference for patients. It's something they have a lot of positive feedback about, where when they're at the appropriate point in their recovery, where they're starting to look at really changing their everyday life routines and patterns and maybe getting a job that's going to support their recovery, having that touch point is so helpful, having those skills and somebody to help sort of look over their resume and help prepare them for an interview, that sort of thing. And then of course, psychiatric and medical treatment, anything that's not available in-house, we want to make sure they get linked to somewhere close by in the community or otherwise accessible. In terms of behavioral health, I do want to note that some degree of psychotherapy is recommended for all patients on buprenorphine, but it is not required. And I always want to make that point really clear because we never want to put up any more barriers than are necessary for life-saving treatment. The evidence is very, very clear that medication is the centerpiece of treatment. It's the engine that makes recovery possible for OUDs. And so for psychotherapy, it's really if the patient is receptive to it and just reminding them that it's there if they're not. The things that we would directly provide on the behavioral health side for addiction include things like cognitive behavioral therapy, relapse prevention, motivational interviewing, contingency management, 12-step facilitation. There's really a pretty wide range. But I also want to note it's not only services that are directed at addiction specifically. It's also that we've talked a lot on this echo about how OUDs kind of rarely occur just on their own. PTSD is one of the most common comorbid conditions. And PTSD, that is a diagnosis where psychotherapy is very, very strongly recommended. And best practice is to integrate PTSD treatment with OUD treatment. So again, it's not only for the skills around addiction and changing those sort of the behavioral side and the psychosocial side that complements recovery, it's also about addressing comorbid conditions, which is so important. Again, ideally, this happens with an in-house behavioral health team because that makes it so much easier to keep that cohesive treatment team. But if not, then this is one of these things that Echo is great for, is getting to know what some other providers in your community, who they are, where they are, what kind of services they offer, and it's much easier and I think also feels safer for the patients often when providers can refer to other providers that they know well. So in terms of the pharmacist, this is a role that often gets overlooked in terms of their importance on the treatment team. Dr. Bhatt has mentioned some really interesting recent literature on just how key the pharmacist is on the treatment team. Of course, I think everybody recognizes for the naloxone distribution medication, but also for patient community education. And they're really the front line in a lot of senses, often the person who's going to catch those yellow, orange, or red flags about aberrant patient behavior that might signal a relapse coming or underway. And then, of course, yeah, all of those education roles and co-prescription of naloxone. For APNs, PAs, midwives, and physicians, this traditionally has been the physician role, but again, on that theme of leveraging capacity, we're trying to look at who else is able to cover these. So managing and administering naltrexone, providing the physical exam, assessing appropriateness for treatment, providing buprenorphine prescriptions, and then importantly, providing training and education to the rest of the team. And again, I'll say traditionally this has been physicians, but again, it can be whoever is trained and qualified. So historically, it's usually been the physician who's the point of contact in terms of making sure that this staff training happens. And you'll see on the left side, the office staff training components, and then on the right side, who should be trained. There are some things that are fairly specific to the role. So for example, you'll see the first one with prior authorizations. That's really good for folks who have that specific kind of designated administrative component. And as we all know, getting prior authorization smoothed out can make the whole machine run so much more smoothly. And then you'll notice that there's several boxes here where it says all staff should receive training on items like basic understanding of addiction and handling challenging behaviors and setting appropriate boundaries. We've talked a lot on this echo about how important the social architecture of the clinic is in terms of engaging patients and retaining patients. And I'll say this is something I hear so much about in terms of patient feedback is, how friendly they felt the staff was, how welcome they feel at the clinic. And that's where these components, it's clear how important they are. That goes along as well with number 6, addressing staff concerns with working with persons with addiction, because of course there are some behaviors that happen with this population that staff who haven't worked in that context before may be unfamiliar with. And it can be nerve-wracking. So it's really important to empower the staff to understand what to expect and what's underneath that behavior so that they can be at ease and also, in turn, help put the patients at ease. All right, so in terms of the original model here, or the most sort of widely replicated model, this is the Massachusetts Collaborative Care Model. I believe it started in around 2007, and I think it started at Boston Medical Center and then was distributed out to about 14 community health centers in a rural area. And this is what we've been presenting on, or what it was drawn from. It's a team-based approach. And in that time, this was back in the days of data waiver, It increased waivered physicians by 375% in 3 years. I think it was from 24 to 114. It was something like that. And if you can just imagine what that would look like if we could get a proportional increase in that amount of time here in New Mexico or in these rural areas, absolutely a paradigmatic game changer. And then very importantly, in addition to increasing, access itself, it also markedly increased patients on MOUD, especially minorities. That's a population that historically we have not done very well by with MOUD. So it's really exciting to see what happens when we can drop those barriers to access significantly and get more people who really need these services in the doors. As I mentioned before, nurse care managers were really central to this process, and we'll look a little more closely at how they became sort of the pinion there. And what these studies found were that one nurse care manager paired with one medical assistant, as long as their roles were effectively structured and they had the support they needed, were able to serve 125 patients. So that's pretty extraordinary, just two team members and 125 patients. And as you would imagine, based on that, this was a very financially viable and sustainable model. Even though this was one of the original sort of oldest school models, this is still very much in use and has just sort of evolved and continues to be developed. So this is just an overview of the patient flow in that collaborative care model. You'll see OBOT-B there, and that stands for office-based opioid treatment with buprenorphine. So it starts with an initial screening assessment by the nurse care manager, then it goes ideally to a chart review with the whole team, so the team meeting once or twice a week to look all together at the chart. Then if it proceeds from there, if the patient's considered appropriate for treatment, it will go to a physician for the chart review, the physical exam, diagnosis, and the decision to prescribe. The nurse care manager handles the prescription generation, the physician handles the signature, the pharmacy handles filling the prescription. Then typically the nurse care manager would actually handle the buprenorphine induction. So that includes the protocol, assessing and educating the patients, et cetera. And then for the patient support and their titration during induction, that would also be the nurse care manager with a physician standing in as backup. Similarly for the stabilization monitoring. And then with the maintenance for follow-up, that would primarily be with the nurse care manager, but with the physician periodically handling those visits. So you can really see here how the nurse care manager is just the core of the flow there. This is a slide for reference. So this will show you what that screening assessment looks like. You'll see there's a lot of different components here, but it's really about getting that kind of whole person treatment and making sure that the team understands what's going on for the patient and making sure they can make a qualified decision, a well-considered decision about whether they're appropriate for treatment. I do want to just kind of, I think this is implicitly obvious here, but underscore the importance of training here. Again, the big idea is about leveraging capacity. And the more that we can train across the system to bring everybody up to capacity, the lower the barriers get in proportion, right? So those are not only the technicalities on the medical and behavioral health side of working with this population, it's also, as I mentioned before, training the whole clinic staff about how to work with individuals with substance use disorders to make sure that we can effectively engage and retain those patients. And it's also about ongoing training, shadowing opportunities, clinical support. It's these system level components that make sure that we're keeping up with all of the rapid changes in this field. That includes things like this ECHO model. So that's, telehealth, teleeducation backup, things like the poison control line where you can call in and make sure that you know everything you need to about a complicated patient. And then also creating policy and procedure guidelines that are public domain. So it's important that they can be adapted or modified to different settings, but particularly important that they're very accessible so that clinics have a place to start when they're trying to integrate these models. And of course, things like billing support, which are easy to overlook, but very important to making sure that everything goes smoothly in the clinic. This again is a reference slide, so this gives you an idea of what that core training entails. And then as we move towards wrapping up, I do want to just put in a note for any administrators who might be on, or if you have a voice with administration, because this is such a key part of successful implementation of medication for opioid use disorders. Because what we find in the literature in terms of barriers to prescribing, administrative concerns are the ones that come up pretty much most often across the board. And things that can do in order to support implementation are above all support the clinical team. So making sure that in terms of policy and then just every day-to-day operations of the clinic, that the clinical team has the time and the resources that they need and that they are, empowered to take the time that they need to provide high quality services to the patient. That includes allowing for regular meetings with open communications, knowing that this is a challenging population. It's so important to have that team cohesion and for everyone to be on board. Coverage issues, of course, if an agency is constantly short-staffed, then with any population, it's difficult to provide adequate care, but particularly with a very challenging one. So that includes that appropriate staffing, such as one RN plus one therapist to 100 to 125 patients. And then very importantly, again, on the training side, allowing time for professional development and continuing education. I just think of how often in the past few sessions on this echo, I've heard some iteration of the phrase in the fentanyl era, and just thinking about how quickly things are changing in this field over the last few years. It's so important that we have time to attend echoes or workshops or whatever it is to make sure that we're keeping up with the latest research and the clinical protocols. And then, of course, on the administrative side, again, creating those clinic policies and guidelines in conjunction with the team so that administration understands what the sort of on the ground concerns are and how they can be smoothed over from a policy side. And then just for all of us, administrators and everyone else alike, things that we can do right now to be helpful on this side. Always being an advocate for our patients. It's so easy to underestimate it, but so important in practice, that one-to-one piece. Then helping to create an accepting and patient-centered environment. That's that, not just anti-stigma, but making sure that patients in general feel really welcome in the clinic. Working within the community and beyond to combat stigma. We've talked a lot about that on this echo and what a difference it can make. And then policy. I know policy is one where I, for one, and I know a lot of other people kind of think of it as a very dry topic, but policy really does save lives. And, if you have any voice, at whatever level, tribal, state, national leadership, that will allow you to enact policies that will benefit communities, that is one of those things that downstream is very literally going to save lives. So some key points there are funding for treatment, drug take-back programs, education aimed at community members, and it's important that community members are involved in structuring and creating that education. Youth engagement, one of the biggest upstream preventive moves that we can make to save us all time and make sure everyone's taken care of downstream. And then, of course, naloxone distribution programs. So those are just a few of the ideas of what you can do now. I know we went through that very quickly, so I'll unshare the screen and see what kind of questions or comments you all may have.